Morning, welcome to my channel Critical Care Basics, and in this channel we are discussing about ECG tutorial, and this is the 30th ECG tutorial, and the topic of today's ECG tutorial is atrial flutter. So let's begin. Atrial flutter. Atrial flutter is an abnormal cardiac rhythm characterized by rapid, regular atrial depolarizations at a rate characteristically around 300 per minute, maybe around more than 250, and due to macro re-entry with a ventricular rate of about 150, that is AV conduction of 2:1. Sometimes this may also change. Characteristic of atrial flutter is the sawtooth pattern. What is sawtooth pattern? The P waves are coming in rapid succession. So there is no isoelectric baseline which gives a rise to this wavy pattern, which is called as sawtooth appearance. So you can see this P waves, one P wave, second P wave, third P wave, then QRS complex. Again P wave, P wave, P wave. These are the not normal P waves but the flutter waves. So after every third flutter wave you get a QRS complex. So the ventricular AV delay or AV conduction is 3:1. The traditional definition of atrial flutter is it is a regularly occurring electrical activity which differentiates this from atrial fibrillation with atrial depolarization rate of more than 240 per minute, absent isoelectric baseline, and the mechanism is macro re-entry. The ventricular rate depends on the AV conduction. For example, suppose the atrial rate or atrial depolarization rate is 300 and AV conduction is 2:1, the ventricular rate will be around 150, with 3:1 it could be around 100, with 4:1 it could be around 75. Sometimes there could be variable conduction. In this case, it could be missed or it could be confused with atrial fibrillation, but the typical sawtooth appearance of flutter waves distinguishes this from atrial fibrillation. Sometimes it may actually deteriorate into atrial fibrillation. 1:1 conduction is a dangerous phenomenon to occur with a flutter. What happens normally is any impulse from the atrium can travel to the ventricle only through one pathway, that is through the AV node. But in some patients there are some accessory pathways. In those patients the current may actually travel to the ventricle before it travels through the AV node because the AV node has a natural delay. This condition is called pre-excitation. One of the examples of pre-excitation is WPW syndrome, in which the PR interval is short and there is a delta wave, which is due to the impulse reaching the ventricles earlier than the impulse from the AV node. In such patients with pre-excitation, if the patient has atrial flutter and you give a drug to reduce the ventricular rate, you give a drug to reduce the AV conduction, then all the impulses will travel through the accessory pathway, causing what is called as 1:1 conduction. This is a dangerous phenomenon. Imagine ventricle contracting at a rate of 300 per minute. The patient will suddenly have hemodynamic collapse and he or she may deteriorate into progress to ventricular fibrillation and death. Therefore, in all patients with pre-excitation syndromes, you should avoid giving AV blocking drugs in patients with atrial flutter. This 1:1 conduction can also occur in sympathetic stimulation. To discuss the types of flutter, let's in brief revise the anatomy of right atrium. Right atrium is formed from two parts. One part is the sinus venosum. Embryonically, it forms from sinus venosum and the primitive right atrium. And these two parts are separated by a muscular ridge called crista terminalis. This crista terminalis starts from the insertion of superior vena cava to the insertion of inferior vena cava, and this is a strong muscular ridge which does not allow impulses to go in perpendicular direction. Therefore, if there is re-entry circuit, the impulses will go anterior to it, either in counterclockwise or in clockwise direction. This is a diagrammatic representation of the right atrium, the superior vena cava and the inferior vena cava openings. They are natural, naturally occurring impediments to the impulse conduction. Crista terminalis is also an impediment to conduction, but most importantly, this zone between the opening of tricuspid valve and the inferior vena cava, cavo-tricuspid isthmus. This is how it would look in left anterior oblique view. But if you cut open the right atrium and see from above, you will see the inferior vena cava and tricuspid valve separated by this isthmus. This isthmus causes an impediment to the impulse transmission and therefore gives rise to re-entry. Therefore, isthmus dependent, most of the flutters which occur are isthmus dependent, and these are called as typical. Therefore, there are two types of atrial flutter. Typical, that means they are dependent on cavo-tricuspid isthmus, CTI dependent. They are called typical flutters. They could be clockwise or anti-clockwise. And the other flutters are atypical, which are not CTI dependent. So the most common flutter is a counterclockwise flutter, CTI dependent. CTI dependence means typical flutter. In typical, the most common is the counterclockwise, means the current re-entry macro circuit has the impulse which is conducted in counterclockwise fashion or anti-clockwise fashion. In this, you can see the impulse going to the left atrium from below upwards, right? That is why it is passing, the current is passing towards V1 and away from lead 2. Therefore, the wavy pattern or the flutter waves are more negative in lead 2 and positive in lead V1. Actually, the flutter waves go like this. So it is very difficult to call what is negative and what is positive. But if you see a visual impression, in lead 2 they are more looking like negative waves, and in lead V1 they are more flutter waves are more looking like positive waves. So this is how counterclockwise flutter will look. I repeat again, counterclockwise flutter is a part of, most common part of the typical flutter or CTI dependent flutter. So revising this again, because whenever you see ECGs of flutter, 90% of ECGs will be typical and counterclockwise flutters. So how will it look? It will be a narrow complex tachycardia unless it is associated with a Van law or intraventricular conduction delay. The atrial activity will be around 300 per minute, regular. There will be loss of isoelectric line, baseline. So you get typical sawtooth appearance with inverted flutter waves in the inferior leads. So this is lead 2, the flutter waves are inverted. So flutter waves are inverted in lead 2 and they are positive in lead V1. And the ventricular conduction ratio could be 2:1, 3:1. In this particular example, this is a flutter wave, this is second flutter wave, this is third flutter wave. So the ventricular conduction ratio is 3:1. Another type of flutter, typical flutter, is the reverse flutter. In this, the current passes in the clockwise direction. Otherwise, it is typical flutter, CTI dependent flutter, but the current passes in the opposite direction. But now you see the left atrium is depolarized from above downwards. That is why in lead 2 you will have positive flutter waves, and in lead V1 you will have negative flutter waves. So all the other parameters of atrial flutter will be same, except that this discordance will be opposite, that is positive flutter waves in lead 2 and 3 and negative flutter waves in lead V1. So that brings us to types of flutter. We have already discussed. There are two types. This is the typical flutter, which is CTI dependent. In CTI dependent flutters, the most common is the counterclockwise flutter. Second is reverse or clockwise flutter, and last is lower loop reentry flutter, which is also CTI dependent, but it only happens in the lower part of the right atrium. Right? Naturally, these typical flutter will always be originated from right atrium. Atypical flutters could be due to a reentry forming in any part of the atria. They could be also from the left atrium or the right atrium. The reentry circuits could form around SVC, around the pulmonary veins, around the scars, around the suture lines, and even the mitral wall. The clinical features of flutter are palpitations, the most common, fatigue, lightheadedness, and shortness of breath. If this progress, then there could be significant dyspnea, angina, hypotension, anxiety, pre-syncope, and even syncope. Physical examination will reveal tachycardia, hypotension, sweating, diaphoresis, evidence of congestive heart failure in form of Krebs. Cardiac auscultation may also reveal irregular rhythm and a gallop rhythm. Flutter waves may be seen even in the jugular venous pulse if you see them carefully. We have discussed in detail about the ECG changes in flutter, but here again we will revise the most common type of flutter, that is the typical counterclockwise flutter. So the hallmark will be no isoelectric line, a typical sawtooth appearance, number one. Number two, discordances in flutter direction. The flutter waves will be positive in V1, V2 and negative in inferior leads. In addition, there will be ventricular conduction at a regular sequence of 2:1, 3:1. In this patient, you are seeing this is the flutter wave, second flutter wave. So ventricular conduction is 2:1. Also, when you see an ECG of flutter, you should also see for left ventricular hypertrophy, whether there is pre-excitation, because if there is pre-excitation, you would like to avoid AV conduction blocking drugs, whether there is associated bundle branch block or prior myocardial infarction. Every patient of atrial flutter should have a transthoracic echocardiography done to see for the size of left and right atria, to see for the ventricular size and function, to see for the pericardium and the valves. And in those patients in which you are planning to do a cardioversion, at least in them you should get a trans-esophageal echocardiogram, which will detect atrial thrombus, which becomes related contraindication, because if you do electrical cardioversion, there is a chance that this thrombus may dislodge and flow into the systemic circulation, causing stroke. The complications of atrial flutter: myocardial ischemia, syncope, dizziness, heart failure, stroke, as we have just discussed, systemic embolization, and tachycardia-induced cardiomyopathy. There are 4 treatment goals, and the approach is similar to what we do in atrial fibrillation. The one is control of ventricular rate. That means we do not correct the rhythm, only keep the ventricular rate less. Second is reversion to normal sinus rhythm, NSR. Thirdly, maintenance of NSR. And lastly, prevention of systemic embolization. The most common drug that we use for rate control are non-dihydropyridine calcium channel blockers like diltiazem and verapamil. In the second option could be beta blocker, especially if the patient is hyperthyroid. If there is heart failure, you could give digoxin plus beta blockers. In acutely ill patient for short period of time, you can also give amiodarone. In atrial flutter, the rate control is slightly more difficult than atrial fibrillation, because these patients are sort of stuck at 2:1 block. Reversion to sinus rhythm, NSR. This is the definitive treatment with radio frequency coagulation or radio frequency catheter ablation. This is the treatment of choice. It has high success rate and low risk of complications. But if the patients are not willing or not the candidates, then you can try anti-arrhythmic drugs. For example, class 1A procainamide or class 1C flecainide. Again, in all these anti-arrhythmic drugs, there is a risk of 1:1 conduction, fast ventricular rate. Second class that you can try is amiodarone or dronedarone, class 3. For hemodynamically stable patient, the best option is to just control the ventricular rate and anticoagulate, right? So, if it is a first episode of atrial flutter and patient declines ablation, then internal or external cardioversion could be done. Pharmacologic cardioversion could also be done by ibutylide or procainamide. The success rate of with ibutylide is 60%, but there is a risk of QT prolongation and torsade. Unfortunately, ibutylide is not available with us. If there is pre-excitation, in those patients, you would definitely avoid the drugs which slow the AV conduction like adenosine, beta blockers, calcium channel blockers and amiodarone. So in those patients, you could try ibutylide if at all you have to give anti-arrhythmic drugs. In patients who are post-cardiac surgery and have pacing wire in place, you can do overdrive pacing. The maintenance of sinus rhythm is difficult because only the success rate is 25 to 50%. Recurrence rate is substantial, hence radio frequency ablation is most preferable to drugs. The preferred site of ablation is carbotrachus pedestimus. Rate of recurrence in patients without prior atrial fibrillation is 23%. Patients who have once deteriorated into atrial fibrillation, the recurrence rate is around 50%. Systemic embolization is a complication of atrial flutter as well as fibrillation. Because the atrial rate or atrial depolarization rate is very high, there is no effective atrial contraction and clot forms in the atria. And this clot can dislodge, go into systemic circulation and cause a stroke. So there is around 6% chance of stroke in atrial flutter, and this can be reduced by giving anticoagulants. The chronic flutter may have periods of atrial fibrillation as well, and the approach to anticoagulation is similar in flutter and fibrillation. You have to calculate the CHA2-DS2 VAS score. We'll just go about it and start anticoagulation. This CHA2-DS2 VAS score is a mnemonic in which each letter stands for a specific condition and gets specific number of points. For example, C stands for congestive heart failure, 1 point. H stands for hypertension, 1 point. H more than 75 gets 2 points. So that explains the risk of developing atrial fibrillation and the risk of embolization, because this is H is given a privilege. D stands for diabetes. S stands for previous stroke. So in previous stroke also you get 2 points because the risk of re-embolization is higher. V stands for vascular disease. Again, second A stands for age between 65 to 74. And lastly, sex, females. So if the total number of points as per CHEST 2018, if the total number of points is more than 1 for males and more than 2 for females, such patients should be given anticoagulation in flutter. While as per the AH and ACC guidelines 2019, more than 2 points for males and more than 3 points in females should be present if you have to plan anticoagulation. The preferred drug for anticoagulation are the direct acting oral anticoagulants, except in valvular heart disease when warfarin is given. Before starting anticoagulants, you have to calculate another score. Again, this is a mnemonic score, has bled. Each letter stands for a condition with points. H stands for hypertension, A stands for abnormal renal or liver function. According to the abnormality in renal and or liver function, you get 1 or 2 points. S stands for stroke, again 1 point. Bleeding, 1 point. Labile INR, INR normally should be less than 1.4. If the INR is more, then you get 1 point. If the patient is elderly, here the age limit is 65. There it was 75. And drugs or alcohol, 1 point for each. So if the Hasband bled score is more than 3, then the risk of bleeding is supposed to be high. This is the Hasband score and the bleeds per 100 patient years. So if the score is more than 3, then there is almost 3 to 5% chance of bleeding. Therefore, we usually avoid giving anticoagulant drugs to patients who have a Hasband score of more than 3. What happens if you are in the ICU or in the emergency department and you get a patient with presyncope and ECG is done and the patient is diagnosed to have atrial flutter? Now, the treatment will depend on whether the patient is hemodynamically stable or unstable. If the patient is hemodynamically unstable, that means the BP is low, BP is less than 90 systolic, patient is having altered mental sensorium. In that case, you have to switch to either rhythm control, that means synchronized cardioversion. So, in unstable patient with irregular rhythm, cardioversion is the treatment of choice. Or if you want to go in for rate control, then you could give IV amiodarone infusion. If the patient is hemodynamically stable, again there are two options, rhythm control and rate control. The better option would be rate control with beta blockers or calcium channel blockers, and you may also try amiodarone. For rhythm control, you have to first, in hemodynamically stable patient, see whether the patient has atrial thrombus. If the patient does not have atrial thrombus and trans-esophageal echocardiography, you may try synchronized cardioversion, or you may do pharmacologic cardioversion with oral dofetilide or IV abutilide. Again, unfortunately, these drugs are not available with us. The ongoing management of atrial flutter. The treatment strategy will revolve around rate and rhythm control. The rate control again would be with same calcium channel blockers, beta blockers, and this would be class 1 indication. For rhythm control, the class 1 indication is catheter ablation. For patients who are not willing for catheter ablation, you could try amiodarone, dofetilide, or sotalol, class 2 indication. You may also try flecainide or propafenone in absence of structural heart disease, again class 2B indication. And if these drugs fail, you again go back to catheter ablation, which remains the treatment of choice. So here we end this lecture on atrial flutter. Hope you are liking these lectures. If you are liking, please share, subscribe and give a thumbs up.